Welcome to Vision for California, a web series of discussions on California healthcare reform, hosted by Senator Dr. Ed Hernandez, Chair of the Senate Health Committee. Today's guest is Dr. Jonathan Breslau, past president of the California Radiological Society.
Well, welcome to Sacramento. Thanks for spending some time. And again, congratulations on your past presidency of being the president of the California Radiological Society. Tell me a little bit about the association and the society and who you're here to represent.
Thank you for involving us in this, Senator. The California Radiological Society represents about 2,000 diagnostic radiologists and radiation oncologists in California. So it involves two specialties, which used to be the same specialty but have branched out over time as the technology has advanced and gotten more sophisticated. Diagnostic radiologists, for the most part, manage and interpret the use of diagnostic imaging for diagnosing diseases and conditions, whereas radiation oncologists are treating cancer, and their technology over the years has evolved quite remarkably to really maximize the radiation dose to the tumor and limit the radiation dose to the adjacent normal tissue. And at this point, it's quite remarkable in the sophistication of that technology.
Interesting. So you're here representing then both entities then?
Yes.
Okay. Well, I mean, let's talk about what's at hand. As you know, 2014 is here. The ACA is moving forward, but more importantly, the Supreme Court ruling, which is going to allow it to continue to move forward. Tell me what you feel your thoughts are on first the Supreme Court ruling and then more importantly the implications of the ACA in your profession.
In California, the planning for implementation of the Affordable Care Act, specifically the healthcare exchange, as far as we could tell, was moving forward anyway. And we were operating under the assumption that some significant part of the ACA in California would move forward for sure in some fashion, that the healthcare exchange would be set up. And so we were already thinking about it and assuming that something would happen. The main impact is, and again related to healthcare exchange, is that there will be a larger number, significantly larger number of insured Californians, and that there's some simplification of how things go for us, but also some complications too because of some new requirements, some of which we actually really welcome. Some of this is within some sub-provisions of the Affordable Care Act, like the accountable care organizations and some of the attempts to structure healthcare delivery going forward. In general, there's more people and it'll be reimbursed. What we're concerned about is the structure of how imaging and radiation oncology operations, how they can be sustained going forward. As I had alluded to, there's a lot of technology, very fancy technology involved in both specialties, which requires a large capital investment. And so to be able to, up until this point, the reimbursement has been adequate to allow the use of the technology and also the development of the latest technology to provide the best care, best diagnosis and best care. That we hope will be taken into consideration going forward, that you're really, it's not purely a doctor doing cognitive skills, although it is that. There's a whole support staff, technologists, and again, very expensive equipment. And we obviously hope that that continues to be supported. I think it's best for the growth of healthcare.
Well, let's follow up a little bit on that. And part of the conversation I've had with all the other health professions that we've talked to is the workforce, but more importantly, the number of patients that are going to be coming on to, that are going to be required to purchase health insurance. Do you guys feel you have enough radiologists in both entities to be able to get that demand, including technicians, or do you feel that there's going to be a need for you guys to increase your workforce as well as addressing the cost issue and the fair reimbursement rate for you guys to be able to do the job correctly?
The full answer we don't really know exactly yet, but I think there's two countervailing trends that will kind of balance out each other while we try to figure this all out. On the one hand, there will be more patients that are insured. Now, in my practice, that actually isn't going to affect anything because we take all comers. It's the same patients; they'll just have different labels on them, so to speak.
Right.
It's the so we don't anticipate a huge change in the volume. But at the same time, there's an appropriate effort to try to really do the right imaging at the right time and not have too much imaging on patients who don't necessarily need it. So we think one will drive up volume and one will drive down volume. And while we're trying to figure out what's going to happen in a longer term, we think we'll be able to tread water for a little while. Also, and this applies to all of medicine, the pipeline is multiple years, and when you realize you have a shortage, it's 5 to 10 years before you can do anything about it. But I would say that in radiology, we face nowhere near the problems of shortage that they would expect in primary care.
Right, right. And we met with earlier on other segments with the primary care physicians, and I would agree that there's a bigger shortage there. I just wasn't familiar with the radiologists. Let's talk a little bit about education requirements and why individuals go into radiology. I mean, what are some of the educational requirements to become a radiologist in the various fields, and do you think that there's still demand and people are still going to want to move in that direction?
I'll jump to your second thing first, which is radiology is a very exciting field, and it's a wonderful field for people who go through medical school and enjoy lots of different areas because you get to work with specialists in all areas of medicine. As far as the training is concerned, and the majority of radiologists pursue subspecialty training, it's a year of internship after medical school, 4 years of residency, and then 1 or 2 years of fellowship. 6 or 7 years is a total after medical school of additional training. And again, the majority of radiologists now are doing fellowships, so they're doing that 6th or 7th year.
Right. Well, if we were to have a shortage, it seemed like it'd be an awful long time to get individuals into the pipeline. So from what I'm hearing from you, at least I'm glad to know that there's not, as opposed to we need to put some work in some of maybe the other areas as well. When I've been serving in the legislature, various bills have come through. Some that come to mind are some of Senator Padilla's bill. Tell me a little bit about low dosage radiation, some of the controversy, and what's your opinion on the safety of it as well, and what are you guys doing to address that right now?
The technology as it develops has been very focused on how to minimize radiation dose at all times. At the same time, within radiology and within medicine in general, there's an appropriate and growing effort to make sure only exactly the appropriate test is requested and only exactly the appropriate test is done. Having said that, the actual radiation dose to the patient for appropriate imaging, and again, we're mostly talking about CT scan and X-ray plain films. The other things don't really have any radiation. Well, nuclear medicine too, but we're talking mostly about CT. The patient's benefit of the test when it's appropriately ordered is greatly outweighs any possible risk for radiation. So, for example, a patient coming in the emergency room, being able to quickly be diagnosed with appendicitis and get appropriate treatment of what is a life-threatening disease, the radiation risk is not the concern at that point. And if you look at the radiation dose and compare it to things like living at a higher altitude for a little while and having exposure to cosmic rays or flying in an airplane across the United States, it's still less than people assume of just other kinds of normal everyday activities.
Okay. All right. Well, let's talk a little bit about, for example, CAT scans. And when you look at the ACA, you look at the country, and you look at all the services that are going to be provided to the consumer, and you compare it to other countries, how does the United States and California in particular compare to, say, other countries with how they provide the health care, more in particular with some of these more sophisticated issues like scanning, etc.? And I know it seemed like in this country, the patient always wants the newest and the best and the brightest. How do we control costs? Is that going to be an effort where you as radiologists are going to try to work in collaboration with the primary care doc to say, look, we're only going to use them at the absolute necessary time, not just every single issue. Is that one way to reduce costs? So tell me, let's talk a little bit about that.
Well, it is absolutely a way to reduce cost, and the American College of Radiology, which is our national organization, has participated in what's called the Choose Wisely campaign, which is coordinated with several other specialties and primary care to look at ways that unnecessary testing can be reduced. And the radiologist is in an excellent position to partner with primary care doctors to choose only the best test at only the right time for each patient.
Right.
So, and this is supported by some of the structure of the ACA.
Perfect. Tell me what's the single biggest issue that's facing right now the radiologist in the state and in the country?
The main thing is what I already alluded to, which is the concern about reimbursement going forward. The reimbursement to radiology had started to go down at the federal level in 2007 and has been on a progression downward since then. Such that the dollars going to imaging are relatively flat compared to about 9 years ago, even though the volume has gone up somewhat.
Right.
It's tapered. That curve has been bent, so that's what we're primarily concerned about. And again, it's highly trained specialists, essential care, expensive technology, but also, and this is in the ACA, there are new kinds of requirements that we actually think are fine in terms of demonstrating quality metrics and communicating with patients and so on. But there isn't a recognition that that also takes time and that also has a cost with it. That's a free add-on at this point, and that's another concern at a time when overall the reimbursement is going down. I think that addressing the dollars that had gone to imaging, which started again in 2007, the most appropriate way to have done that, and some of that will be put in place going forward, but the most appropriate way would have been what you had been alluding to earlier, which is reducing the inappropriate overuse as opposed to reducing the reimbursement per scan.
Right, I got it. All right. Well, thank you very much for joining me in Sacramento. I know you're a past president. I'm assuming you have many duties to do still on your board. Thank you for serving, but more importantly, thank you for being here in Sacramento and joining me as we discuss healthcare.
Thank you, Senator. Very much appreciate your interest.
Perfect.
This presentation of Vision for California with Senator Ed Hernandez featured special guest Dr. Jonathan Breslau, past president of the California Radiological Society. We invite you to check back for upcoming segments. Thank you for watching. See you next time.